Sorry, let me start that again. Welcome to the webinar. We'll be talking about prioritization in an era of scarcity today. And we are recording the presentation. We'll stop recording during the discussion and Q&A at the end. Feel free to use the chat or the Q&A for any questions or comments at any time. Today's webinar is part 1 of a 3-part series. So we'll be hosting part 2 and 3 in November and December to continue to talk about ways that implementation science can support you during these challenging times. So today's webinar is a collaboration between RAISE and NASTAD. Our collaboration focuses on strengthening implementation science through public health at state and local EHE health departments. So we host these webinars. We also provide tailored health department consultations. We do site visits and reverse site visits. And we also will be hosting the 2026 Evaluating EHE Implementation Workshop. We encourage you to reach out if you have any questions or would like to talk with the RAISE team about how implementation science can support your EHE work. And you can also reach out to us at NASTAD if we can support any of your capacity building needs for HIV prevention and surveillance. So applications are open for the Evaluating EHE Implementation Workshop. This is a 2.5-day in-person workshop on program evaluation, focusing on how implementation science methods can help you with program evaluation. So we encourage folks doing evaluation work at local and state health departments and EHE jurisdictions to apply. Applications are open until November 14th. The workshop will be held in Seattle, April 7th through the 9th of next year, and I'll be putting some links in the chat once I'm done with my slides. Okay, so just to get to our presentation for today, we have Dr. Matt Golden. He's a professor of medicine at the University of Washington and is also the director of the HIV, STD, and HCV program at Seattle King County, and is also the director of the UW Center for AIDS and STD. So Matt, over to you.
Great. Are you guys able to see my slides?
Yes.
Great. Well, it's great to have so many people on this call. And I'm going to be talking about setting public health priorities in a period of declining funding, but also new opportunities. So I want to just start by pointing out, a lot of the impetus for this talk relates to where we stand in terms of public health right now, which for many people feel it's a period where we're under threat. And I just want to point out that U.S. history sort of goes through cycles. I made this slide based on something from Arthur Schlesinger Jr., who was an historian who was also an advisor to John Kennedy. And you can just see that we kind of go through these cycles where we have more liberal eras and more conservative eras, times when we focus on activists or more limited government, property rights versus equality. And, the eras change over time. Now, I don't say this to, be a Pollyanna. And I don't think that these eras and the shifts are preordained. I just point out that the Mycenaean Greeks, 3,500 years ago, had an alphabet called Linear B. And then between 1100 and 800 BC, the Greeks forgot how to write. The Roman Empire, there was indoor plumbing, and then most of the Middle Ages in Europe, there wasn't. So it isn't that everything is preordained that it's going to get better. And I think that should be, maybe a warning against complacency. But at the same time, I do think that things are likely to swing back because that's typically what happens. So one of the big challenges here is trying to interpret where really are we in terms of the budget. So the president's budget for 2026 was pretty sort of stable Ryan White funding, continuing the Ending the Epidemic initiative, terminating the CDC HIV prevention and surveillance program, which includes the testing and education and outreach. And this is then going to supposedly be folded into this new AHA program. There'd be other things that are terminated: Ryan White dental programs, the AIDS education and training centers, the minority AIDS initiatives, HOPWA, so the housing program for people with AIDS. NIH supposedly was going to get a 40% cut. STD funding was going to be folded into this sort of broader program. And then the Senate proposal, as I understand it, and some of you may have more up-to-date information than I do, is sort of status quo. Doesn't really mention this AHA thing. Ryan White continues to fund dental and the Minority AIDS Initiative and the ATCs. There's small increase in NIH funding. HOPWA continues to exist. There's no block grant for the STIs. So I just think we don't really know what's going to happen. This is going to have to unfold as our elected leaders make decisions. I do think that based on the reconciliation bill that's already passed, there will be significant cuts in Medicaid and in the insurance subsidies on the exchange unless Congress and the government do something to change that. And that will impact our work, but a lot of uncertainty. So why focus on prioritization? Well, some of it is this uncertainty related to the funding. But I'd also just say, you know, we're always committed to improving the work we do. That's independent of whatever happens to the funding. So we always want to be in a position where we're open to taking a hard look at what we're doing, and are we really funding the best things and using the people's money in the most efficient way? And that's not a partisan issue. I also think we face changing epidemiologic circumstances, and there are scientific advances which offer us new opportunities, and in some instances should probably lead us to question some of the things we've done. So it's sometimes said that a physician seeks to be always uncertain and never in doubt, which is to say we aren't paralyzed by our doubt, but we're open-minded. And I think that's the direction we want to be. So with those thoughts in mind, what I'm going to do is talk about our current context, both in terms of epidemiology and new opportunities and dilemmas, and then give you some thoughts on prioritization. So on this slide, you're looking at trends in new HIV diagnoses in the United States between 2008 and 2023. And what you can see is during that time, we've had a 30% decline in new diagnoses, but sort of stable numbers since about 2019. And that decline in new diagnoses was pretty broad-based. We had a 35% decline in new diagnoses among Black Americans, which is great. But despite that, 38% of all diagnoses occur among Black Americans, who are only 12% of the American population. During this same time, the percentage of cases diagnosed in men who have sex with men went from 58% to 70%. So we're getting a more concentrated epidemic, not a less concentrated epidemic. In many ways, I think we have good progress, but we still have the disparities, which have always plagued us. And it does sort of seem like our progress has stalled. We also have a growing epidemic of syphilis that's diversified. So you can see that rates have been rising among men since the 1990s. You see this big decline. I'll get back to that more recently. And then increasing in heterosexuals, and that's really focused on women since about 2005. And we have this epidemic, which is in the heterosexuals, which is really concentrated in a vulnerable population of people, many of whom are using substances and living homeless. I think the other big shift, which is important here, is this increase in the proportion of cases that are syphilis of unknown duration. For those of you who do a lot of syphilis work, I suspect there are a lot of you on the call, but maybe not everybody. If we have a case of syphilis where we don't have a prior negative and the patient doesn't have primary or secondary syphilis based on their symptoms, and we can't connect the case to somebody who has primary or secondary syphilis, they're called syphilis of unknown duration. You can appreciate among men, almost 50% of the cases are unknown duration. Among women, where we don't do a lot of syphilis screening traditionally, 60% of the cases are of unknown duration. And that has big implications in terms of treatment. We also have this rising number of cases of syphilis, of congenital syphilis, which is accompanying, of course, the increased number of syphilis cases in people who can get pregnant. Our number one priority as it relates to syphilis is avoiding the devastating consequences of congenital syphilis. And I know these are very old data from the 1950s, but I just want to point out that among women who had untreated early syphilis, only 18% are going to have a healthy baby. So 79% of them are going to have a stillbirth, a neonatal death, or a baby born with congenital syphilis. So this is really a devastating infection when it occurs. People acquire syphilis during pregnancy and are not treated. And that's what we're trying to avert. Now, my last episode I just want to point out to you is the trends in drug overdose deaths. And this is a devastating epidemic which dwarfs the HIV epidemic, is the truth of it. So in 2023, we had over 105,000 deaths related to overdose in the United States. At the peak of the AIDS epidemic in terms of mortality, which was 1995, we had about 5,000 deaths from AIDS. We're currently somewhere between 5,000 and 8,000 deaths per year from HIV-associated causes. So I know not all of your programs focus on overdose, but this is really dwarfs anything else that we're doing in terms of the magnitude of the effect on the population. So I would say overall, good progress on HIV over the last decade, but maybe we've stalled out. And what we face is the social marginalization of HIV, where additional increments in progress are likely to acquire something new. The remaining cases are increasingly concentrated in a population which is harder for us to effectively reach and treat. And we have sort of a mirror image of this in many ways with syphilis, these rising rates in women, which again are affecting a marginalized population, with a growing proportion of cases that are unknown duration, particularly in women. And that's so important because that means these patients are supposed to get 3 shots of benzathine penicillin, but we have a benzathine penicillin shortage. And this is really a big burden on public health and particularly our disease intervention specialists, who are often charged with trying to make this happen for people to get those weekly shots, and on the healthcare system. And of course, then we also have this giant epidemic of overdose death. On the other side, we have some new opportunities and in some instances, some new dilemmas. So the first opportunity is doxypep. And a couple things I'd point out here. So this slide is just summarizing the 3 randomized controlled trials we have of doxypep. You can see across these studies, if we look at STI outcomes overall, you see a fair amount of heterogeneity, right? In doxypep study, which was the one conducted in the United States, the absolute risk reduction in STI was 140 per 100 person years, so more than 1 reduction in STIs per every person year. In IPERGAY, it was really only about a quarter of that. But if we look at the syphilis impact, I would say those are pretty consistent. So 70 to 90% reductions in syphilis, really dramatic reductions in syphilis. And across these studies, you're looking at about somewhere 9 to 11 cases reduced per 100 person years follow-up. What this ends up meaning is that the average person in, say, the doxypep study was taking about 4 doses of doxycycline a month. And they take about 43 extra days of antibiotics per year to avert 1.4 STIs. 70% of which were asymptomatic, half of which were gonorrhea, 43% of which were chlamydia, and 7% of which were syphilis. I really think what we want to concentrate on is the syphilis. The rollout of this in the places that have done it, been early adopters, is pretty dramatic. So these data were published from San Francisco, 51% reduction in syphilis among men who have sex with men and transgender people. Big reductions in chlamydia, no decline in gonorrhea. I'll get back to that in a minute. These data come from an analysis that Tim Menza did here in Seattle, really very similar. So 46% reduction in syphilis among cisgender men. What was impressive in our observation here was we also saw this reduction in women, not quite as big, but big, 35.5% reduction in syphilis cases relative to what we would have anticipated we see had the trend simply continued as they had. Now, I point out we have not observed a decline in congenital syphilis or syphilis in pregnant people. So we would suggest that whatever decline was resulting from the doxypep, which I think reflects transmission from bisexual men, that's probably not the same population of people who are getting pregnant and giving birth to people with congenital syphilis. That doesn't mean it's not important, but it doesn't probably solve our congenital syphilis problem. Now, concurrent with this, you do see a shift toward increasing gonococcal resistant to tetracyclines. I don't think this is all related to doxypep. You can see that these numbers are going up prior to the rollout of doxypep. But as of the first quarter of 2025, 3/4 of the isolates have high-level tetracycline resistance. So I think that really explains why we're not seeing a gonorrhea effect at a population level, and really emphasizes this probably does have this effect on the gonococci in terms of accelerating resistance. I think that you also see an impact from doxypep on other off-target bacteria, which is to say, not sexually transmitted or not typically sexually transmitted bacteria. What you're looking at here is a study our group published earlier this year. And if we compare the doxypep users to the non-users, what you see is the doxypep users have less staphylococcal carriage. So everyone or about a third of people carry staph all the time, about a third carry them intermittently, don't carry it. So we see more carriage in the doxy non-users, but you see a big increase in tetracycline resistant Staph aureus carriage in the doxypep users. We also see an increase in group A streptococcal carriage, and I think that's sort of reflecting a different mechanism. So what's happening there is probably we're wiping out the susceptible streptococci in these patients' oropharynx, and the group A strep are almost always tetracycline resistant, and so they're moving into that unoccupied niche. I would point out, though, we don't exactly know how important this is. So we're seeing these off-target effects. Whether they matter or not, I don't really know. I think another big dilemma, not so much maybe an opportunity, relates to STI screening. So STI screening has been a mainstay of STI control and prevention for many years. Screening programs for gonorrhea were rolled out in the 70s, screening programs for chlamydia in the 80s. And this was mostly justified as a way to prevent major morbidity in women, in particular infertility. We have 3 randomized controlled trials which have looked at this. What you can appreciate, they're summarized on this slide. In all instances, the relative risk of pelvic inflammatory disease was lower in the people who were screened than the people who were not screened. Women who were screened, not screened, although only one of the trials had a statistically significant result. However, whether that really translates into a decline in infertility in particular, I think we really don't know. A recent study from the Netherlands followed 5,700 Dutch women who had been screened for chlamydial infection from 2008 to 2022. So they had annual CT screening, and what they looked at is one group had symptomatic chlamydial infection, presumably all treated. Another group had asymptomatic PCR positive chlamydia and were treated. And a third group they identified were serologically positive for chlamydial infection, but had not been treated for chlamydia. So presumably this is a group never got screened or whatever, never got treated, but they have evidence of chlamydial infection. They looked at a self-reported outcome of PID ectopic pregnancy or infertility or pregnancy. What you can see is that chlamydia was associated with PID ectopic pregnancy and tubal factor infertility. Those are things which we've sort of thought we've known for a long time. This study is confirming that. Though it was really only associated with symptomatic chlamydial infection, and the absolute risk in the women was low. So about 1% higher with chlamydia than not without chlamydial infection. So does that justify the screening program that we've had? We also now have a randomized controlled trial of STI screening in men who have sex with men. So this was done in Belgium, was powered as a non-inferiority study in 5 clinics. So one group of people got 3 site anatomic screening every 3 months for gonorrhea, chlamydia. The other group was screened at baseline, but not thereafter. And what they looked at is, was screening non-inferior to, was not screening non-inferior to screening, and it wasn't. But it really only affected chlamydia, and the impact was pretty low. So you had to screen 12 men for a year to prevent 1 asymptomatic chlamydial case, 27 men to prevent 1 symptomatic screening test. Remember, that's 27 men, at 3 sites, 4 times in a year. So it ended up, was this really a big benefit? And did it really justify the level of effort we've invested to prevent a small number of symptomatic chlamydial infections? I think it's important to remember that gonorrhea and chlamydia in the pharynx and the rectum are self-limited infections. So these data come from a cohort study that we did in Seattle, where we enrolled 140 men who had sex with men, followed them for 48 weeks. They self-collected pharyngeal and rectal specimens once a week, and we tested all these specimens at the end of the study and estimated the duration of infection. So you can see in the absence of therapy, we estimated that pharyngeal gonorrhea would last 16 weeks, rectal gonorrhea 9 weeks, rectal chlamydial infection 13 weeks. However, remember that when you screen, you aren't identifying the infections at the very beginning. You're presumably identifying them somewhere after their acquisition. So the duration after screening is going to almost certainly be shorter than that. On top of that, when we use these very sensitive nucleic acid amplification tests, some of the infections we're identifying are probably not viable. So I think that the true duration of averted infection is likely substantially shorter than what I'm showing you here in terms of what's accomplished through screening. What this led to is that some people are saying now it's time to stop. So these, you can see these a couple papers on this. We conclude that in the absence of symptoms in high STI prevalence populations, frequent STI screening should be limited to HIV and syphilis. So I see this as both a dilemma and an opportunity. Decreasing our emphasis on gonorrhea and chlamydial screening has the potential to save resources, to unburden our patients and the healthcare system, maybe to improve PrEP retention. I do think that the issues are different here between people who can get pregnant and people who can't get pregnant, and that probably the first step in this is to de-intensify the extent to which we're emphasizing this in men who have sex with men, and I'll come back to that later. So another big opportunity is long-acting antiretroviral therapy. This slide is showing you the results of the Latitude study, which was a randomized controlled trial of over 400 people living with HIV who had suboptimal adherence to antiretrovirals. Now, this was a randomized controlled trial at an open-label design. People were supposed to become virologically suppressed before they started their long-acting antiretroviral therapy with cabotegravir or rilpivirine. Not everybody did that, but most people did. The thing I want to emphasize, though, is that looking at the treatment-related failure, you really do see a pretty dramatic decline. So 26% in standard of care versus almost 10% in the cabotegravir rilpivirine. And it gives us the first signal that that there really is an opportunity here using long-acting antiretroviral therapy to improve outcomes in people who have not been doing well. We now have a number of smaller observational studies looking at the use of long-acting cabotegravir rilpivirine in viremic patients. So not the exact same population that you were really seeing in the Latitude study. And across these, it looks pretty good, not perfect. And I know these different studies have different designs, different lengths of follow-up, but across them, about 80% of people get virologically suppressed. About 10% of people develop fail therapy with new resistance mutations. So not perfect, but I think this is really where the opportunity resides, to make a difference for the patients who aren't already doing well and are really struggling. Now, the other big opportunity maybe with long-acting antiretrovirals is for PrEP. Here you're looking at the Purpose 1 study, which was a study of lenacapavir for PrEP. It enrolled over 3,200 cisgender, gay, bisexual, and other men who have sex with men, and transgender and non-binary people. They have a very high background incidence of HIV infections, so 2.37 infections per year. That's high. It's randomized controlled trial. The lenacapavir, for those of you guys don't know, twice a year injection. So, that's not really that much, a lot easier than the cabotegravir, it seems to me. What you're seeing is with the TDF-FTC, the absolute risk reduction, so with a generic drug, was 1.44 decrease of new infections per 100 person years. The incremental benefit of the lenacapavir over the TDF-FTC was an additional 0.83 infections reduced compared to the TDF-FDC. This was really an effective intervention. There were only 2 infections in the lenacapavir arm. But the cost creates a huge dilemma. So that the cost being advertised is $30,000 per year per patient, roughly. Let's say you get it for $20,000 per year for our Medicaid program in Washington State. We're looking at a $42 million increase per year to the Medicaid budget. At $20,000 per year, it's $2.4 million per case averted. If we have to pay the full $30,000, it's $3.6 million per case averted. The cost per case averted using generic TDF-FTC is about $12,000. So this is really a massive difference. And whether we can afford to do something like this, I think, is very uncertain. And I would just point out to you, I like this paper from the New England Journal. We'll make these slides available so people can look at it if you're interested. That if physicians shirk their duty to act as financial stewards when making medical decisions, the end result will be worse health outcomes for the population at large. And I really think there's a real ethical dilemma here in terms of prescribing a medicine that costs this much money that would potentially cost $3.6 million per case averted or delayed. I don't have an answer to it. It's a tough one. I also want to point out an opportunity which may be underappreciated. So this is just showing you the anticipated year in which patents will expire for different antiretroviral drugs. And I really want to emphasize to you 2028 for the end of the patent for dolutegravir. So typically, the price of an antiretroviral really plummets a year after it goes off patent. And I think it's reasonable to think that we could have a good antiretroviral regimen that will work for about $1,000 per year by about 2029. And are we preparing for that world where the price of these drugs is going to plummet and we have a huge windfall? Or will we not have that windfall because we've done other things? So big opportunity to redirect funds to address things, to me, like social determinants of health, which are the underlying factors which are why so many of our patients seem to really struggle. And I acknowledge that operationalizing that sort of redirection of resources is challenging. So in terms of the opportunities and dilemmas, what I'd say is for doxypep, very high demand in our experience around here with very large population level effects. It does induce resistance to both target bacteria and off-target bacteria. I do think we want to consult our patients about this. Doxypep is not PrEP. Most people who get syphilis are going to be cured and do just fine. HIV is a more serious infection than syphilis for most overwhelming majority of people. I would also say that though decreasing infections in men allows public health to concentrate scarce resources on women and on preventing congenital syphilis. And that opportunity is an important one. In terms of STI screening, I think there's really growing momentum away from the widespread gonorrhea chlamydial screening in an effort to decrease cost and the population's exposure to antimicrobials. I do think the issues are different here between men who have sex with men and cisgender women. I would also say some good news here is that gonorrhea and chlamydia are probably not as morbid as we've sometimes said, particularly in women, and that's important. I do think that changing what we're doing presents a challenging messaging issue. I'm not sure how we reconcile doxypep, which increases antibiotic use, with decreased screening. And I think there's a real dilemma there. Finally, I think there are big opportunities in long-acting antiretrovirals. The most important of those, it seems to me, is treating people with HIV infection who have not otherwise been successfully treated. Cost is a big issue here, particularly for the PrEP. That's much more of an issue for the PrEP than for the treatment, it seems to me. And I think that generic drugs will represent a huge opportunity and one we don't want to squander. So now let's talk about prioritization. And why are we focusing on this? Again, I think we face the prospect of real funding cuts. We are committed to the work, improving the work we do, and that's independent of the funding cuts. We have new epidemiologic circumstances, and new advances and challenges. And I think as we think about this, we really want to be open to changing what we fund and not just scaling back what we're already doing. We want to look at the totality of our work and say, are we really doing and funding the things that make a difference? There are a lot of factors influencing prioritization. So there are the diverse stakeholders, there are the funders, there are elected officials, there are affected communities, and there are the people charged with implementing these interventions, in particular, the people within our own health departments, but also the medical providers out in the community. There's the scale and the morbidity associated with these problems. There's the issue of how effective and scalable are the interventions we have available. So we can't concentrate on a problem where we have nothing we can do that makes a difference. And in particular, what are cost per unit outcome, which is something which we mostly don't look at. I think we want to think about what is the essential role for public health. So can someone other than public health provide a service that we're providing? If so, is this really where we want to concentrate our effort and resources in an era of scarcity? There are equity considerations. And then I think we want to think about the long term and the importance of our really critical infrastructure. So again, I had started this talk talking about how sometimes funding and policy and political landscapes cycle. And we want to think about our long-term goals. So are there things or capacity we might lose that will be particularly hard to rebuild? And if there is, we may want to prioritize keeping it available to us at some level. So I don't have, an answer on what the priorities will be, but I have this is what I come up with, and you guys can tell me later that I'm wrong, or you can email me. So I think the highest priority is sustaining and increasing HIV viral suppression among people with HIV. My second priority would be preventing congenital syphilis, and in particular, making sure that we're treating and case managing pregnant people and pregnant capable people who have syphilis. I think we need to sustain our core surveillance system. So there may be things we can scale back on, but we can't lose our ability to monitor what's going on. I think we want to sustain linkage to care for HIV infection, which is often integrated with surveillance. I think we can't back down on at least certain aspects of drug user health in the midst of the epidemic we're up against, particularly Narcan, which is such an important intervention in preventing overdose death. We're going to want to continue to, of course, to treat symptomatic STIs, particularly syphilis. Something I'm probably not going to talk about much here is promoting HIV STI control within the healthcare system. I think that we often neglect that. And then there's the STI and HIV case finding we do ourselves in PrEP. In terms of sustaining critical infrastructure, for places like us, I think we have to sustain our sexual health clinic. We could scale it back if we had to, in terms of numbers of hours and services, but we can't lose the clinic altogether because we won't get it back. I think we have in Seattle these low barrier clinics. I'll touch on this more in a little bit, that we want to continue to promote. Again, we have to maintain our core surveillance infrastructure. We have key community partners who we need to continue to support. So there are aspects of the infrastructure that we need to prioritize. So with those thoughts in mind, I'm going to focus on just 4 areas, which really sort of mirror, for the most part, the pillars of HIV prevention, which are treatment, diagnosis, PrEP, and I'm not going to use respond. I'm going to say partner services, which I think is a broader, sort of more important part of what health departments do. And I'm mostly going to try to take a public health perspective as we think about these. So the first thing I want to talk about is treatment and sustaining viral suppression, which, remember, was my #1 priority. A big part of what has been promoted in recent years is something called data to care, the idea that we'll go out, find people who are out of care, relink them to care. This has been evaluated in 2 randomized controlled trials. One was done by our group. I'm going to show you actually the CDC multi-center trial. This was done in Connecticut, Massachusetts, and Philadelphia, enrolled almost 1,900 people who had been out of care for at least 6 months. DIS or other public health staff went out, tried to relink them to care. The key thing I wanted you to look on here is, although the intervention did in some instances lead people to re-engage, it had no impact on viral suppression. And I think that the failure here is that we were, not that people did a bad job, but that people were being relinked to a system that hadn't worked for them to begin with, and it still didn't work for them. The way we've tried to deal with this, and some other places have also begun trying to do this as well, relates to changing the organization of the healthcare system. For us, this started with something called our MAX clinic, which is a low barrier clinic. It's a walk-in HIV care clinic. And I want to point out, this is not an urgent care clinic. People are getting all their HIV primary care on a walk-in basis. They get high intensity case management. They get incentives for coming and getting their blood drawn and for achieving viral suppression. There's a lot of coordination with jails and supportive housing and others. And in a controlled analysis, not a randomized controlled trial, enrollment in this low barrier clinic, this MAX clinic, increased viral suppression about threefold. So I think in terms of prioritizing viral suppression, treatment is, I think, the intervention which best integrates our goals of preventing morbidity and mortality and preventing new infections. And that's why it rises to the top of the list. We have a highly morbid infection that's if it's not treated, and we have an awesome intervention in antiretroviral therapy. But I do think we have to ask ourselves, do the things we do work? And I think in terms of data to care, particularly surveillance-based data to care, it doesn't work very well. And that to make it work well, we have to integrate healthcare system change. That if we want to relink people to care, we have to relink them to a system that's going to work for them. And it really raises the question, do we reprioritize resources to promote easier access to HIV care, which really requires working with the Ryan White programs and healthcare provider organizations? And does that rise to the top in terms of our prioritization, which may be something that a lot of the health departments are not most currently focused on? I think we want to optimize the use of antiretroviral therapy, and we have to think about cost. This has not traditionally been something health departments have necessarily focused on. But I think we want to use greater use of generic and lower cost drugs and selective use of long-acting antiretroviral therapy for the people who cannot otherwise achieve viral suppression. And I want to point out that that use of those long-acting antiretroviral therapies, it's not just the cost of the drugs. To be successful with this requires other things besides just the meds, in terms of making sure the patients come in to get their meds, nursing staff, all of that. Let's talk about HIV testing. This has traditionally been an important part of what all of the health departments do. It continues to be important. In 2021, CDC funded over 1.7 million tests, a lot of positives. But I'd also point out that only about 22% of new diagnoses are the result of federally funded testing. So most of the testing is not being done by the public health system. It's being done by the healthcare system at large. So in King County, and I'm only using this as an example because I'm closest to the data here, 21% of new diagnoses last year were through publicly funded testing. So almost dead on what you saw in these national data a few years ago. 2/3 of those publicly funded new diagnoses occurred in a single sexual health clinic. One thing we don't do very well is estimate what does it cost to achieve an outcome, and yet that is key in terms of prioritization. And the reason often it's hard to calculate this is what cost do I want to include when I'm making this estimate? So if you're doing CBO-funded testing, often the CBOs are funded to do more than one activity. So how much of their work was testing and how much of it was something else, and how do I attribute the cost there? In a sexual health clinic, how much of the funding is related to HIV testing? It's not just the cost of the test. That's not the way to think about this. You have to contribute something to the staff time and the overhead. I came up with some numbers here. These are not perfect numbers. These are just estimates. A couple different CBOs that we fund. One of them had a cost per case detected of about $23,000. The other didn't find any cases, so it would be infinite. In our sexual health clinic, I'm estimating maybe around $44,000 per case detected if we assume that 20% of the clinic's budget relates to HIV testing. In primary care, if you were testing a 0.1% positive population, it would be about $40,000. Finding a case of HIV is expensive. That's a big part of what I want to convey. That doesn't mean we shouldn't be doing it, but I do think we have to say, is publicly funded testing reaching a population they wouldn't otherwise get tested? And are the things that we're not doing to promote routine testing as part of primary care or in other venues, ERs, other places, which might be a more effective way to find new cases of HIV infection? In terms of PrEP, there's a real question. What is public health's role in promoting and providing PrEP? It varies a lot depending on where you are in the US and how much PrEP is available where you live within the primary care system. So in Seattle, we have a sexual health clinic. We have about 1,200 people on PrEP, but that's less than 5% of all people on PrEP in King County are getting it from us. There are about 35,000 men who have sex with men on PrEP in King County is what we're estimating. I am concerned that access may be affected if lots of people lose their health insurance. So we need to be thinking about that as we prioritize and prepare for that eventuality. I do think that there are opportunities to to simplify PrEP and decrease its costs, which has the potential to increase our capacity to provide it to a larger number of people. So in particular, less frequent follow-up, less gonorrhea and chlamydial screening, which is that I was talking about those screening tests. How much is that really buying us in men who have sex with men? In terms of the long-acting PrEP, unlike the treatment, the cost, I'm not sure, isn't an insurmountable barrier. This, I acknowledge, may be an idiosyncratic perspective for me, but at $30,000 per patient per year, I don't know that we can really roll this out in big numbers. These just show you some changes in our public health Seattle and King County PrEP implementation guidelines. As I said, we I think are going to be making this available so you guys can look at the guidelines. They're on our website. We have decided to make routine screening for gonorrhea and chlamydial infection a shared decision-making activity when people are coming in for PrEP. So something the doctor or the medical provider needs to talk to the patient about. It's no longer recommended, and that reflects the fact that these are not morbid infections. There's no sequelae associated with them. They are self-limited, as I told you before. It's uncertain that there's any population-level impact associated with this, and we're putting a lot of antibiotics in the patients without knowing that they're really benefiting much. Now, last thing I wanted to touch bases with in this area are partner services. This is usually a very large part of a total HIV STI program in terms of cost. It focuses on HIV and syphilis. Our partner services programs have three integrated objectives. They involve case investigation, so information we're collecting for epidemiologic purposes, efforts to identify outbreaks. There's partner notification and testing, which is really a case-finding intervention for HIV and syphilis. That's our traditional focus. And then there's case management considerations. So we're linking people to care and other services. So for HIV and syphilis, a lot of this is about treatment. Often for syphilis, it's about ensuring people get 3 doses of benzathine penicillin, which, as I alluded to before, can be very challenging. And I suspect all of you who do this work know that this can be very challenging. We also want to link people to PrEP, and I think now maybe doxypep. And then, of course, for a subset of the patients, Narcan and drug treatment. So you have to ask yourself, well, what are we accomplishing? On this slide, I'm just showing you on the left hand of the slide, case finding indices, and on the right side of the slide, brought to treatment indices. This is, in other words, how many new diagnoses of HIV are there per person receiving partner services, or how many new cases of syphilis are treated per person with syphilis as a result of partner notification. What you can appreciate in both the US and the UK is that these indices of effectiveness are declining. And they've been declining over the last 20 years. A lot of things contribute to this. I think changes in the role of government. I think how people meet their sex partners have fundamentally changed. One way or another, these numbers have gotten worse. I would also point out that the way we measure these are, in some instances, probably overestimating their effectiveness. So in a study from Ann Cope, you can see they looked at if we exclude the people who were treated for syphilis, the partners who were treated before the partner services interview, that brought the treatment index gets even lower. So we're at a point, maybe 1 in 10 syphilis cases do we find another case? Maybe 1 in 20 HIV cases we find another case. The reality is that partner services probably identify fewer than 5% of all HIV cases in the United States and fewer than 10% of early syphilis cases in the United States. So it accomplishes something, but maybe not a home run. And I think we want to be open to the prospect that the same staff we have doing some of this might accomplish more in a different case finding activity. What you're looking at here is just the results of a jail testing program. Overall, we're seeing about a 4% positivity for new syphilis diagnoses in 2 different King County jails. Their effectiveness in finding cases varies some. So one of the jails finds has the potential, I think, to find a lot more cases than the other, though I think we have to prove that still. Neither of them find anywhere near the number of cases that the sexual health clinic finds, but they find a lot of cases in heterosexuals and potentially in women and the partners of women. So should we continue to provide partner services at the current level, or should we scale up jail-based testing? I don't have an answer to that question. I just raised this with all of you as we think about what do we really want to prioritize as we go forward. I think the other thing to consider is our investment in ensuring that everybody get 3 shots of benzathine penicillin for syphilis of unknown duration a priority. We have 2 studies which have looked at this. The first was published by our group, by Travis Hunt earlier this year, saw no difference in serological outcomes in people with syphilis of unknown duration who had a high titer, so greater than 1 to 32, whether they got 1 or 3 shots of benzathine penicillin. Subsequently, these data have not been published, but they were presented earlier this year in Montreal. CDC did an analysis looking at almost 19,000 people with syphilis of unknown duration diagnosed between 2016 and 2021. You can see on the figure here, no difference between 1 and 3 shots of benzathine in serological outcomes. And here they're looking, you don't really see any difference no matter what the titer was. This is not a randomized controlled trial. What I would say is that in clinical practice, increasingly what we've been doing is saying for non-pregnant people with syphilis of unknown duration, if we don't think that they can come back, we give them 1 shot of benzathine, and then we give them 28 days of doxycycline to take, and we acknowledge that some people will not take all of it. But we don't invest scarce DIS resources trying to make sure that they come back for all of these shots. We just don't have the resources. So I think, talking about partner services, I would say case finding is typically low for HIV and syphilis. I think there is an opportunity to use outreach to link people to other services, that case management component of partner services. I think we can improve efficiency. And I gave you this example of using maybe just 1 shot of benzathine with doxycycline in people with high titer syphilis of unknown duration who are not pregnant. And insofar as our goal is to increase syphilis and HIV case finding, we need to think about, could our staff accomplish more doing something else? So in conclusion, I'd say we have a lot of opportunities related to HIV STI. There's the long-acting ART, doxy-PEP, healthcare system change. It seems to me those are all important opportunities. Many of our opportunities involve some dilemma in terms of implementation. I think that's true for long-acting ART, particularly as it relates to PrEP and cost. I think there's issues related to off-target impacts of doxy-PEP, but I'm not sure how clinically significant those are. I think that the uncertain federal funding mandates that we really take a hard look at everything we're doing, that we need to prioritize, but that prioritizing needs to be more than just saying, what will I cut? We want to really think about what will make the biggest difference as we seek to advance the public's health, and think beyond what we're currently doing to take that more global perspective. I do think as we think about this, though, we want to think about what is our critical infrastructure and what do we want to sustain when the pendulum, I hope, swings back and maybe our funding situation is a little better. So that's my last slide. I'm happy. I'd be interested in people's thoughts, and I'm happy to try to take questions or try to answer questions if people have them.